To move too much. I'm Diane Stein. I'm a pediatric neurologist. I see adults also with developmental disability. And it turns out the niche that really seems to need filling is epilepsy and autism, and I'm doing more and more and more of it. I have a great time with the kids and the adults that are having these issues, whether it's true pure autism or developmental delay or whoever kind of comes with mom and dad. But today I was really going to be focusing on epilepsy and autism. When I give this talk for the autism groups, it has information about what is epilepsy. I'm giving the talk today for the epilepsy groups, so there's information about what is autism. We may go fast past that. All right. So I like to start with a case. I met a young man just the other day. Seriously, I always put these things together a little late, so it was just the other day. And he came in, boy, it really was just the other day, and he had had his first spell. He was at school. He had been having some social stuff, not a big deal. No one really came in because of autism at all. And he was noticed by his teacher to have slumped in his chair, to have peed on himself, to then fall out of the chair. He needed to be carried to the nurse's station. Mom and dad came, and when mom got there, he was, lights are on, nobody's home. She swears it was more than an hour that the paramedics came, that they assessed him and said, well, you can put him in the car and bring him home or bring him to the hospital. Probably the hospital's better. Well, that also means the paramedics didn't recognize that this was a prolonged non-convulsive seizure, and that's kind of a big deal also. Now, interestingly, they brought him into the hospital. He had a little eval. They did know that he was having that social trouble I talked about. He has these explosive behaviors. Things have to be a certain way. Other things just kind of hit me on the face when I first saw him. Mom says that night he peed the bed. The next morning he wasn't right and he couldn't talk just right anyway. So he probably had another seizure that night. So this kid needs attention. And on the first visit we mentioned a little bit about the chance of convulsion, non-convulsive status epilepticus, the need to have meds at school, the likelihood that this is epilepsy, what epilepsy is. Oh, and by the way, should I drop the bomb that I think it's also autism? That's kind of an interesting question on the first visit when I've already spent an hour and a half, right? But that's him, and that's where we're starting. They did talk about the emotions, like I said, and they are the ones that then said, what do you think about autism? I don't have the slides in front of me. I only have them behind me, so I'm going to look back occasionally. So it's not rare. I see a lot of kids who show up for their first convulsion. Often the first convulsion is either around 7 or 15 years old. There's something about the growth spurt or the hormones that often bring it out. But I'm seeing more and more folks because the autism groups are telling the other parents that when kids are in the middle of doing and then they stop and stare, that's a seizure, or at least it could be. And so we don't always know. With our very low functioning kids, they can spend so much time kind of interested in things without talking that you're not always sure. But for the kids that are talking to us and they're saying, I really want to, that part's easy. If they're doing something they like, and even if it's stimming, there's a difference in their face. There's a difference in what they're doing. We know our children, and we can tell when it's a zone out or a stim a lot of the time. And when we can't, there are other ways to do that as well. So we're going to talk about that a little bit. And it goes both ways. Kids with autism have an increased risk of having seizures. Kids with seizures have an increased risk of having a lot of different developmental things. The interesting increase in autism, is it because we're noticing it more? Do we finally have a label for it? Is it like after World War II, men came back and we called them shell shock? And after Vietnam War, we called it PTSD. Well, there was PTSD after World War II. No, it's not just that. There is something leading to this increase. We don't know what it is. We know more and more certain factors, though, that are linked with autism. First of all, what is autism? It's a group of behaviors. It's not a diagnosis in and of itself, at least in my clinic. Saying someone has autism to me is like frozen dessert. You don't know what you're getting yet. You don't know if we're talking vanilla ice cream or if we're talking baked Alaska. Pistachio sorbet, I don't know yet. But I do know they're going to have certain symptoms in common. And it's as many as 1 in 500 children back in 2001 were those statistics, and now they're saying up to 1 in 101 children, 110, 4 times more in boys than girls. So what is that about? Well, maybe we're not looking as hard, and the girls are more likely to do pretend, and boys are more likely to be loud, but there really may be something to do with that X chromosome also. So some of the early signs, many of you in the room already know about this. I'm going to go fast. The poor eye contact, those things, they're all in your handout. Some more early signs, the lack of social gestures, the lack of to be picked up. If you don't have words and you're 12 months old and you want mom or dada, there should be a pick me up instead of a where someone's, you know they're upset, but you don't know what's in their mind, and that frustrates them and you. Also, not like smiling and going when you walk in the room. So you guys probably all know this. You may walk in the room, Jeffrey, and you expect that turnaround, and you may not see that. Those are some of the signs. The red flags, this is the part where I tell to the doctors and to the referring physicians and to people with expertise in epilepsy or other neurologic things that aren't really having their radar up. These are the absolute radar up. No babbling by 12 months, no gestures by 12 months, no single words by 14 months, no phrases by 24 months. I wish I had this in front of me. Or loss of language. And that's another thing that seems to be variable. Some of my patients never lost language, and their first word was basketball instead of hi, bye, or here you go, or uh-oh. Those are kind of typical for, well, here you go isn't. That was my daughter's first word. But those are kind of, I know, it was a weird, interesting first word. Here you go. But when the first word is basketball or street or car, you're going, that's a different first word, and then some kids get a bunch of words and lose them. Other kids, they really don't get language till later. When there's the regression, we're talking a different kind of category that takes it out of, in my mind, vanilla ice cream. We're already heading towards sorbet. So the 3 main things is a qualitative problem with being social, a qualitative problem with communication, and a rigidity, a problem with transitions, things have to be a certain way, looking at the part instead of the whole. Now, I already kind of talked about how it's not all one thing. It definitely does come in flavors, and at least that's the way I look at it. And the diagnosis of epilepsy can be tricky. Some people may accuse me of overdiagnosing epilepsy in those with autism because, you know, if all you have is a hammer, everything is a nail. I try not to have quite that approach, but it is kind of nice to treat epilepsy and see people get better, and so I'm always looking for it, and the incidence is rather high. But you do have to be a little bit careful. I mean, some of the behaviors that look like non-convulsive seizures really are just behaviors, and it can be quite tricky. So how common is it? There's a great big increase in epilepsy if you already have autism. And I like some of these numbers, and they're not in the handout. So depending on who you read, 3 to 22% fold increase, and 25% will have what they call clinical seizures. What is that? That's something that no one can miss. So some people will say 40% of kids with autism have epilepsy, but there's a difference between having epilepsy and having clinical seizures. A clinical seizure might be, I fall down, and nobody missed that. Whereas epilepsy might have non-convulsive seizures that are brief, that are just those little ones I keep demonstrating, kind of different. And then the study has been shown that there's an 800%, is it percent, increase in mortality between typical kids and kids who have autism and epilepsy. We compare the typical kids and the autism and epilepsy, and they're thinking that SUDEP has a lot to do with that. Sadly, I have one patient whose very first seizure was at night, was prolonged. He gagged and vomited. They found him on his back. Vomit had gone into his lungs. He was intubated for 4 days. He's back to baseline, yay, but that was his only seizure. How long do I keep him on meds? What do I do? How do I know the med's working? Could he have died that time? Yeah, he could have. And that's hard, but it's real, and that's the other reason where I don't get too upset if people say, are you overdiagnosing it? Well, let's see. I think it's important. All right. So who are the ones that are more likely to have seizures? At least the clinical seizures are more likely, like I said, when they get to be around 7 or around 15. But also the lower functioning the child, the more I've got to have a high suspicion. And if there was a regression, the more I have to have a high suspicion. The other one I didn't write here is, of course, if there's a family history. And there are the severity links that and it's kind of the same thing, that the more impaired you are from one thing, the more likely you are to have the other. So why do they have such a correspondence? Well, number one, they're both from the brain. And when the brain isn't acting right, it can do epilepsy easily, no matter what the problem is. And autism is from the brain too. But there are syndromes that do both, like Dravet, like some mitochondrial disorders. Disorders of energy metabolism. And folate metabolism is all in vogue right now. There's some people talking a lot about cerebral folate deficiency, which I find interesting. There's a number of different problems where I'm wondering if there's more stress on our brain nowadays, either because all the stimuli coming at us, the TV, the bright colors, the traffic, the noise, then the diet not being a very normal, healthy diet because everything's got to be shelf stable, and the constriction of the diet. My kid will only eat chicken nuggets and French fries. And then all those stresses, when you already have some kind of mild chromosomal problem, that maybe if you had that and you lived in Little House on the Prairie, you wouldn't look so autistic. So that's sort of what more and more people are thinking about why it's coming together. There are specific syndromes we can easily test for now where they come together, like Fragile X, Rett syndrome, Angelman's. And in fact, on the DSM criteria for autism, it says, except Rett's. But it doesn't say, except Fragile X, except Angelman's, except mitochondrial, except, and they're changing the criteria so that it's not so silly to just say except one thing. And Landau-Kleffner, infantile spasms are both epileptic syndromes that we know very much about. We know that with Landau-Kleffner we need to look for changes in sleep, and that we look for a regression in language, and that it's later onset, it's not your 18 to 21 month, and that anti-epileptic meds and anti-inflammatory meds are supposed to help quite a lot. With infantile spasms, that happens, of course, during infancy, and the diagnosis of the epilepsy comes first. But there's a great chance of having autism after infantile spasms. Not everybody does, but there's a pretty good chance of it. And so we always watch for that. And so that's where I take a breath. Okay, so now we've kind of talked about, gosh, there's a lot of autism, there's a lot of epilepsy, they're connected, and there's syndromes. And so if I'm the clinician and Troy comes in to see me, and I've got to figure out, does Troy have something bigger than behavior problems, social problems, epilepsy? Is there something else that's leading to Troy's seizures and autism? Then what I want to do is figure out, okay, what kind of testing do I want to do? And it depends on what I see in the clinic, of course. The testing we first think about is, in this talk, is am I testing for epilepsy? So on Troy, of course, I'm going to start with an EEG. But what kind of EEG? So we can talk about the meaning of a normal EEG. Now, usually when people talk about EEGs, you guys probably all know, we're talking a 20 to 40 to 60-minute test of recording. The person goes in, they get all the leads put on, it takes 45 minutes to get the leads on, then they sit for 20 to 40 minutes. I think we should take at least as long as it took to get the leads on, but that's just me. And then when they're done, you take all the leads off, you wash their hair, they go home. Now, if during those 45 minutes, let's say, there's no seizures, that doesn't mean there never was or never will be. It just means while I watched. It's kind of like if I'm watching you guys and you don't eat during the hour I'm talking, doesn't mean you never eat, it means you didn't do it while I watched. Now, if I were to look at you guys for 24 hours, yeah, I'd probably see you all eating. And right now, I can assume you all eat. I can't make that assumption with epilepsy. So then we go, well, do we want to do one 45-minute test or not? Well, how about if we do 2 or 3 or 4? And back when I was first practicing out of residency, I remember there wasn't even the consideration of doing prolonged EEGs unless you thought someone had something on an MRI, which back then was really had to be kind of big. and then we would admit them for a prolonged EEG. Now, it's quite a different story, but we used to say you can have 7 normal EEGs and still have epilepsy. But usually by 7, there's a 95% chance you're going to find it if it's there. We don't really do that so much anymore, or at least some of us don't. So some places will bring them into the hospital, and there are definitely advantages to that. Near where I work, you have to be in for 3 days, or at least schedule 3 days. I don't really understand that. There are plenty of places where it can be 1 day, whatever. But with that, you go in, they hook you up, you're on video, you're on audio, and you're in a bed, and you're not supposed to move much because you've got the wires coming off your head going to the machine by the bed, or going to an amplifier that you're holding. And certainly it can really tell you what seizure type, what does the video look like during the EEG abnormality, and it can show you how often are there seizures. It can tell you about sleep. There's lots of really great things, and it's the only way to localize for epilepsy surgery in most people's mind, and that's probably going to be true forever. We can.
Autism loves that.
What?
Autism loves that.
What? The prolonged?
The kids just love that.
Oh, I know. I was at the hospital the other day, and I was seeing somebody else, and the tech came out, and the mother and the tech were in the hallway. I have to digress. And the mother said, "Will you please stop getting on the intercom and saying, 'Don't touch your head'? It's driving my son crazy." And I didn't hear him. And then the next thing I heard was, "Whether I'm a good parent is not up for debate right now." I went, "Oh no, that is just not good." So I don't know that I'd be very happy tied to a bed. You know, I mean, I don't think it's just autistic people that don't like being tied to their bed for 3 days. Now, there's other ways of doing this. There's the ambulatory EEG where we put all the same electrodes on. We use a very similar amp, and there's a couple different companies that do this. And you do the recording and find out how many seizures, and if you have good video, what does the child look like when they're having a seizure? Is there a change? And it could be that I also watch the whole video. Okay, I can't watch 3 days, I just can't. But I can fast forward through 3 days, or I can ask the parents, stay with the child all the time, or if you're the patient, push the button anytime you feel something funny. And if there is one of those, you push the button, and I'm going to get to watch the video and see what the behavior is. Then I can show you guys the video, and I can say, "See that one? That one's not a seizure." And then if there's another one that is a seizure, I can say, "And see that one? That one is a seizure." And then we can have the discussion. I can't tell them apart clinically. Can you? Can you tell that one from that one? No? Then we have a problem. But if we can tell one from the other, then we can count, or we can get an idea if the meds are working when we're not in front of a camera and having the head all wrapped up. And I see some advantages to not having to do more and more tests every time we're wondering if the meds are working. I'm just thinking. Okay, so the patient would wear it at home. It doesn't replace, like I said, for a pre-surgical eval. And I already said that. I do this a lot. You guys already figured out that the person's not confined to a bed and that it's less expensive. One of the things that I like to point out is that whether you're autistic or not, if you go into the hospital, you probably feel like you must be sick. Something's wrong. I'm in this foreign environment, and there's nurses, and there's IVs, and there's blood pressures, and there must be something wrong. And I think it's less psychologically difficult if you're getting it done while you're at home. I'm just thinking. So there's a setup. There's a number of different kinds of these. This is just one that I finally, after trying 3 systems, have landed with, because the tablet over there can be drop-kicked and not break. I find that important. After I broke about 6, not me, but someone else probably drop-kicked them. And then there's no wire connection on some of them, and so the child can be doing whatever. I have mom and dad, I said, you know, soon what we're going to do is put the camera and clip it to your hat. And then whenever you look at the child, as the child moves, you're going to keep the child on video. We haven't gotten that good yet. But it's a really nice idea that we can then have the tablet at home, have a camera, and we can record them day and night. I think it's exciting. The disadvantages are that unless I can remote in and look at it, the child can do this a lot, and then I can lose those leads. And we're getting to the point where remoting in is going to be pretty exciting. The other disadvantage is that if someone's doing this, I'm going to get a pretty crappy quality EEG, but at least if I get like 8 hours of it, and then there's only 4 hours of jump, really, I mean, we know what happens. If I can get 4 hours without the jumping up and down, I got 4 hours and I got a full night's sleep. And so I do have, you have to kind of tell them, pretend you're in the hospital, sort of. Try and do some things that keep everyone a little quiet for part of the time. Some of the older systems are really not good quality. And so you'll find many doctors will say, I will not do an ambulatory. There's no way I'll ever do it. And some folks don't know how to do the billing. And billing does drive medicine. It's just a fact. And if the doctor can't bill for it in a way that'll keep them able to keep the machine going and keep the clinic going, they're not going to do it. So some doctors won't do it because the old machines were crappy, and it took me a long time to get on board and see that the new machines were better quality. And then the other thing is that it could come loose, and then the other thing is that we have to have parents that won't trash the machine, or I'll send them home with little like corsets, and I'll say in the first couple hours, every time he or she goes for the head, you say, oh, we're going to have to put on those no-no boards. And you leave them on for 2 minutes, and then you take the no-no boards off. And then when they're good, you go, that's great, you're doing great. And then when they go for the head, no boards, I'm sorry, doctor's order, and you put it back on. I have had such good success with that because after a while, people, they're not, it's not that hard to learn that every time I go for my head, I get a no board. It's not fun. So we have found, it's been found, and it's very well published, that you can see some things by doing, whether it's in the hospital or not, by doing the prolonged EEG. So now, let's say I've got someone who mom and dad noticed the little stares, no big convulsions, no times of slumping in the chair, no peeing on themselves, moderately high functioning person, and we have an abnormal EEG. Now, what do we do with that? There's a big debate in the world about this. Some epilepsy doctors say, well, we got to treat it. But when I say why, I don't always get the clear answer. Some epilepsy doctors put it right out there, and I love that. And I've talked to a group of autism doctors that are conservative, where they admitted 32 patients for a 2-day EEG. And of those 32, I think 28 had abnormalities. And of those 28, only 19 had seizures. And the ones that didn't have clinical seizures but had abnormalities, so that would be a very small, or a portion of them that's not tiny, they put them all on meds, but they all got the same med. So we're going to put everybody on the same med and everybody on the same dose, and there wasn't a significant improvement. To me, that doesn't mean I don't need to treat. It means not everyone does well on the same med, or some of them might not have improved, or I don't know. There's a lot of other factors. The current thinking is that when there's EEG abnormalities, and it's really rare, it may not be something we need to treat, but if there's seizures that are not convulsive that I can't see, and that's defined as 3 seconds of rhythmic activity, got to treat that. I know that that causes not such good effects on the brain. When there is spells that are 1 second, half a second, 2 seconds, and they disrupt the background activity of the brain, then we also know that that's not good for the brain. We want the brain to practice social behaviors, walking and talking and learning and math and pragmatic and semantic language and all those good things. I'd like my daughter to know when there's a hat on the doorknob, she can move the hat and open the door. I'm trying to teach her that one. Can't see through the hat. There's all sorts of different levels of what we want them to learn, but what we're not looking for is, let's learn how to have more seizures. And there's, at the last American Epilepsy Society annual meeting, someone used a word I really liked, which was recruitment for the neural net. And when you have seizures, you get a network of neurons, of nerve cells, that are all working together to spread the news, all working together to spread the high voltage burst of electrical energy. Well, if it started somewhere, that central area where it started was the recruiter. And that recruiter, I think of it like the gang charismatic leader, goes out and gets other cells to join with him or her. I don't know that many, but anyway. And then those guys recruit more, and then they recruit more. And the reason we treat is to try and let them not talk to each other so that they can go and do other jobs, and so that then the network gets unbuilt. And then we got this lone guy that maybe even he will get interested in doing something else, or whatever you don't use, you lose. So if I speak Spanish, and I've spoken Spanish since 7th grade, and I practiced and practiced, then I'll probably going to continue to speak Spanish. But if I go and learn Italian, which my husband's trying to get me to do, which is hard when you already speak Spanish, I think, because I always say everything wrong. But if I learn Italian and I speak it for 6 months and then I stop, I'm not going to know how to speak Italian. It's done. And that's what we want to do when we have seizures. Part of the reason to treat is to learn how to not have seizures. Not everyone can grow out of it, but that's part of what we're doing. I've kind of already gone into that it's important to treat for all of these reasons. The other one I think is huge, though, is we don't want non-convulsive seizures disrupting sleep. I think sleep is pretty important, and it's a little bit underestimated, but you can't learn when you're sleeping. You just can't. And I don't know how many times we've seen these kids that you know, they say, oh, he falls asleep during ABA. And I'm like, well, you got him up at 7. He went to school. He got 3 therapies. At ABA's at 4. And he was seizing during the night. You know, really? He fell asleep during ABA, you think? So, you know, sleep is kind of important. Isn't that a cute picture? And so then the next step, so now that was what testing, and when are we going to treat and who we're going to treat. And I'm treating those who have clinical seizures or who have really kind of significantly abnormal EEGs that I can correlate with something usually, or that have a lot of sleep disruption, and I'm looking then, my goal then would be to improve learning and improve sleep and improve alertness. And then the next question is, okay, we're ready to treat, now what are we going to do? Do we all have a consensus? And it used to be, when I was first training, that everybody with autism probably should go on Depakote. I'm not kidding. I had an autism specialist who trained me who told me everybody with autism should go on Depakote, because Depakote is broad spectrum, and it works on most kinds of seizures, and because it stabilizes the mood. Well, I don't know about you, but I don't find that there's any time where I could say everybody that likes frozen desserts likes vanilla. Some people don't like vanilla. Some people don't do well on Depakote. It's not always the med, of course. So if we're going to treat, what are we going to treat with, and how are we going to find if we're doing better? And it's really, really, really very hard. There are very few funded studies where, let's say, the company that makes drug X went out and said, we're going to test our drug versus their drug on autistic kids. And then you have to narrow it down. Are you talking autistic kids with mitochondrial problems, autistic kids with folate receptor problems, autistic kids with Dravet? You know, you can't make it that big, because also autism isn't one thing. But the other problem, and my husband stated it really well for me, was when you're highly motivated to change a situation, it's hard to change just one thing at a time. So I have a lot of patients where they're seeing 3 or 4 different doctors, and during the course of therapy of a new medicine, they've started diflucan, and they've started GABA and melatonin, and they're also doing maybe some other kind of therapy, and they started 2 of them at once and then another one, and they know that after the diflucan the child looks worse for 2 weeks, and then they call me and say that he looks worse, and could it be the med? And I'm like, well, I don't know, because we did everything else at the same time. So it's very, very hard to figure out what the good and the bad of the meds are when we're changing multiple things. On the other hand, it's also hard to say, don't change anything for 6 months so that you can do my plan. And so we have some problems with it. There is a very interesting study out there. At first I was kind of poo-pooing it, but I really read through it. I found it fun. It's by the parents. They sent out, I don't know, 3,000 surveys, maybe more, asking the parents their perception of the efficacy and their perception of the side effects. And they had listed all sorts of therapies, alternative therapies and traditional therapies. Interestingly, in the first part of it, the traditional therapies included the ketogenic diet and the modified Atkins. And then in the efficacy part, they put ketogenic and modified Atkins in the alternative. So I find that at first it's traditional, and then when it worked, it's one of the alternatives. So keep up with me here, it's a little interesting. But many people were using a combination. And the alternative therapies and the dietary therapies together were thought to be more effective than the drugs by these parents. But again, when you use a diet therapy, you're investing a lot. And when you invest a lot in any therapy, you have an vested interest in it turning out good. I also do think, though, that when we cut out the crap, often kids do look better. So I'm not going to belittle that diets can be very important. And of the alternative therapies, surprise, surprise, the ones that we already know work for epilepsy were deemed most effective, and that's modified Atkins and ketogenic. Ketogenic is not something you can do by yourself or at home. It's not a complementary and alternative therapy. We can just go and find someone who wants to do that today. It's very dangerous when used wrong, so I want to throw that out there. Now, of the non-traditional treatments, they were mostly targeted towards oxidative stress. Remember how I was talking about all the stresses of modern life probably bring out a greater disability from the same bottom line genetic or whatever problem, so that if you had that problem and you were in Little House on the Prairie, you might not look autistic or epileptic, and if you have it now, you might. One of the big theories is oxidative stress. That may be it, but that's what they're talking about most of the time. And the authors also said that most of the non-traditional treatments that were perceived as helping epilepsy were also perceived as helping the symptoms of the autism themselves. The traditional, or this is a list of the non-traditional treatments, it's in your handout, and the traditional treatments were deemed more efficacious for stopping seizures, or kids who went on meds had fewer seizures. There was 4 main meds they talked about, and it included Lamictal, Keppra, Depakote, and ethosuximide. And they're listed by their generics. And of them, when the parents listed what they thought were the side effects and what they thought were the good effects, if they looked at all of them without any distinction as to what was the seizure type, what's the cause of the autism, what kind of EEG did they have, was it the right med, none of that was looked at. It's just one big group of parent perception. There was a perception that Lamictal had the least side effects. And there was perception that the Depakote was a little better than the Keppra, but that the Keppra had more irritability than the Depakote, and neither one of those were, you know what I'm saying? But there, again, it's a big, big, big group. There was a lot of other meds that they could have added to the list. They chose the ones that were the most likely to get that when they looked at the parent response, got the most responses. So now there are other therapies. One of them, let me see if I can get it. Sorry, Jim. All right. So there's a therapy called the VNS. You guys may be familiar with it. It's pretty darn small. And I've also had talks with folks who do autism and epilepsy work about if the VNS is helpful. And some docs were, I guess, for a while, using any sign of epilepsy as a reason to put in a VNS, because the VNS has been shown effective for depression. And so if it works for depression, maybe it'll help with the symptoms of autism. And the answer to that is, well, yes and no. But at least we do know that the VNS works for epilepsy, whether you have autism or not. And whether you have autism or not, it improves your quality of life by a number of different measures, and we have data on it. And so I'm not going to use epilepsy as an excuse to throw a VNS in just anybody and go, oh, you've got epilepsy and autism, VNS is now the new Depakote. But I am going to say it's not off the shelf because someone has a developmental disability, and it can be helpful for the epilepsy and have fewer side effects than some of the others. What is it? It's a little stimulator that would go in the chest on the left side and then go up to the nerve, and it would stimulate the vagus nerve, and the vagus nerve sets some of the tone of the brain, and by doing that, it decreases seizures. There's a myth that it takes 2 years to work. What it really is that it can work in some people very quickly, but the effect can increase over time. Just like if you're getting into a rhythm of going to sleep at the same time every day and you have insomnia, you may still have insomnia for a while, but once you get into the rhythm, you're going to get your sleep cycles all worked out, and then you're going to go to sleep easily. It's a cycling effect. So that's the VNS, which is another treatment. And then we have, again, me going over how we may not be looking for a cure on every person, but we are looking for an improved quality of life. I'm looking for a surge protector that does not cause the child to be sleepy, that does not change the function of their computer, but allows them to be the best they can be, the most cognitively alert, the most interested in what they're doing. I'm looking for better speech if we can find it, for better interaction if we can find it. And we're not looking to drug someone just to calm down their seizures. Seizure control may be number one goal, because I don't want them to have sudden unexplained death due to epilepsy, which I try not to talk about because it's so depressing, but also because I want them to be thinking clearly and living well. And so it's important to treat for those reasons. And again, when I do Troy's EEG, we're not going to put him on meds because his EEG is normal or abnormal. We treat Troy, not the EEG. And we may then wish to test for a cause for autism and epilepsy in Troy, and we may wish to treat that epilepsy in a way that allows him to sleep well, to feel good, and we want to set the bar that high. Why not? This is my contact information. I thought I would run over 60 minutes. It looks like I probably didn't.